Welcome to First Star Let's Chat, an athletic therapy podcast. I'm your host, James Gardner, certified athletic therapist, certified strength and conditioning specialist, yoga instructor, human being. This platform, for the pros, by the pros, anybody in the performance space, and beyond. Welcome here to share in the stories of professionals, experiences, journeys, learning along the way. It's a platform to connect, to network, and to be a part of a community that cares, with conversations that matter, experiences that resonate, and generate ideas, thought-provoking, organic dialogue, passionate pros. Brought to you as always by First Star Therapy, Mobility Tape, Epic, and Benchmark Athletics, in association with the Canadian Athletic Therapists Association. It's First Star Let's Chat, an athletic therapy podcast. Thanks for being here. Thank you for being a part of it. Welcome to First Star Let's Chat, an athletic therapy roundtable brought to you by First Star Therapy. I'm your host, James Gardner, and this is a platform for the pros, by the pros. Passionate pros, organic dialogue. Let's chat. Thanks for listening. Let's roll.
.47, that means it's takeoff time. Welcome to Let's Chat. This is session 14. An athletic therapy roundtable. So ground rules before we get going. Please ask any questions through the chat box, either directly to myself or to the group, whichever way you feel comfortable. If you feel more comfortable doing so with your microphone, please just unmute yourself and ask the question when queued up to do so. This is being recorded for the purposes of going back in time and reviewing the discussion, as well as saving the world one conversation at a time. We really appreciate you being here. Things are moving in a positive direction on this chat and beyond. And tonight's going to be a really, really special, I think, case. We're going to do a case study with Dr. Desai, who's here this evening. He's going to take us through a case that, a fairly recent case with another therapist who's on here as well. So we'll have some input and some dialogue back and forth in terms of that. We'll ask some good questions and have some good dialogue in terms of interactions between surgeons and therapists, as well as a case that Dr. Desai worked on, as well as myself in terms of the rehab. So we'll have a couple rehab scenarios, a little bit of back and forth on that, and any questions that you feel are relevant, please feel free to do so. So without further ado, I will introduce our guest for this evening. Dr. Sagar Desai is a certified orthopedic surgeon with the Royal College of Physicians and Surgeons of Canada. He began his education at Western University in London, Ontario, where he completed his Honours Bachelor of Science in Kinesiology. He then completed his medical degree at the University of Toronto. Dr. Desai subsequently attended Western University for his orthopedic surgery residency. He completed his residency in 2013 and became a fellow of the Royal College of Surgeons of Canada. During his residency, Dr. Desai concurrently completed a master's in science in medical biophysics. This master's focused on orthopedic biomechanics, joint kinematics, and surgical implant design. Following his residency, Dr. Desai completed 2 accredited subspecialty fellowships. The first fellowship was completed in foot and ankle reconstruction at the University of Toronto. The second was an AO trauma accredited fellowship in orthopedic trauma at Sunnybrook Hospital in Toronto. Dr. Desai is currently a trauma foot and ankle surgeon at Humber River Hospital in Toronto. And academically, he's involved in surgical education and research. He's involved with several multi-center randomized controlled trials in orthopedic trauma. He's published numerous peer-reviewed studies and textbook chapters in both orthopedic trauma as well as foot and ankle reconstruction. He's an adjunct professor in the Department of Surgery at the University of Toronto and an assistant professor in the Faculty of Health Sciences at Queen's University. Dr. Desai, thank you so much for taking time out of your busy schedule to be here this evening. I'll let you say hi to everybody, and then I'll jump into how we got to know each other, and then we'll get into the nitty-gritty of it all.
Thanks a lot for having me. I'm happy to be here. pretty busy with everything that's going on with COVID, but getting used to this kind of virtual chats, virtual meetings. So it's nice to be a part of it.
Yeah, really appreciate you being here. I know I'm speaking for everybody in the room as well. And you and I haven't seen each other in a while. We had a quick chat the other day. We stayed in virtual contact, I guess, while things are going on here, but even before that. So Dr. Desai and I actually got to know each other at random when I was working at the university, at York University, with the football program. Dr. Desai covered one football game, and having him on the sideline was just about the best thing you could have with a surgeon who is readily available and willing to be there and have dialogue both on the sideline and beyond in terms of injury evaluation as a resource, etc. And the best thing about you, well, not the best thing about you, one thing about you, other than the fact that you went to Western, was that you played basketball at university, right? You were an athlete for most of your university career, your undergrad career, is that right?
Yeah, Western. I played for 4 years at Western. That kind of what spurred my interest in orthopedics. So yeah, I played 2004.
Nice, very good. So that's kind of a common theme with a lot of the therapists in the room. We played sports or attempted to play sports, and then wound up in the field based on an interest, for sure. Everybody's dying to know, and I already asked you this, so I know the answer is no. Tiger King?
I'm not onto Tiger. I actually don't watch TV at all. I don't have cable. During COVID, I watched Ozark all 3 seasons, and I went back to do some Prison Break. So that's what I'm in the middle of that right now. So with my extra time, that's what I'm doing.
All right, perfect. And I know you don't have much extra time. We had a brief chat about how this whole thing was affecting you. We have a running scoreboard in terms of Tiger King, and that now puts us at 8 no's. We're just a strong lead, I think, maybe the strongest lead to this point in terms of guests for the no's. So I like that. It's turning the way that I don't know, whatever. It's turning that way. Anyway, listen, I really appreciate you being on. I know you're really busy. Give us a little rundown in terms of how things have changed for you as an orthopedic surgeon with this downtime and physical distancing.
Well, it's been obviously for everyone life-changing, practice changing. We went from working 5 to 7 days a week to clinically being at the hospital now only once or twice a week. We went from running 2 clinics to 3 clinics a week to now I do 1 clinic every 4 weeks. Kind of the hospital really shut us down hard. And we're really just doing everything virtually now. So unless the patient is acutely post-op or has an acute injury like a fracture, obviously we see them in person. Aside from that, everything is kind of virtual visits, and it's challenging because you're making decisions based on conversations and video as opposed to in person, which kind of we haven't really ever been taught before in our life. So it's challenging. It's a little nerve-wracking as well because you're making decisions that when you're not fully informed. So it's been a huge difference there. I do trauma as well, so I still do a week of trauma, and probably from March till about 2 weeks ago, no one was really getting hurt. We would do 5 cases a day. I went down to about 1 case a day. Just the volume went down. No one was driving around. No one was on their bikes. No one was doing anything. So the volume of trauma has really slowed down quite a bit. It's picked up in the last 2 weeks or so. So now I'm back to my regular kind of 4 to 5 foot and ankle fractures a day, but it was very slow for a while. So there's definitely challenging, as everyone has, financially as well, and just getting used to being at home more often. And it's been challenging, and I think we're all kind of excited to get back to work, which hopefully will be in the next kind of 4 to 6 weeks, we're hoping.
Yeah, I appreciate the insight. I know it's been just in talking to you briefly. There's a lot of positives about it, but certainly from an orthopedic standpoint and from a practitioner standpoint, a lot of the people on the chat are having a tough time. It's really hard to relate to people through a camera all the time, especially when the hands-on and the orthopedic tests are crucial to what you do. So. Yeah, I think it's we just hang in there and we hope for the best, right? And you and I talked a little bit about it's also nonstop at home, right? You go from your clinic, and you speak about a clinic, and we think like, 9 to 5, we're seeing patients every hour, but I mean, you're talking about really quick turnover in a regular clinic, right? How many patients would you typically see in a clinical day in the hospital?
On my busy day, I'll see 70 in a half day. So the challenge is now from 70 to a half day, which is pretty efficient, right? We have a full cast tech. We have 2 or 3 cast techs, 3 or 4 nurses. We really go through it quickly and efficiently. And now you're kind of calling those 70 patients, and it takes me almost a week to do the same amount of work that I'd normally do in 3 hours. So and it's not nearly as efficient, not nearly as productive, but it's definitely challenging. And we're just waiting for the go-ahead for our hospital. Right now, our hospital has one of the highest volumes of COVID in the country, so we're going to be a bit slower than some hospitals to get back going, but we're just waiting it out.
Yeah, what a tough shift, and even then, you get off the calls or on the calls, and the kid, the dog, whatever goes on in there seems to just be nonstop, right?
Yeah, people don't answer their phone when they're supposed to, and it's disconnects, and it's just like you guys are the same challenges we're having. It's much more difficult. It's much more inefficient. It's just hard, but then we're just kind of learning a new way of practicing, which we've never been taught before, and never had to be taught before, just like you guys are. And it's challenging, but getting used to it now, and you kind of trust that you're making the right decisions, even though you don't have all the answers.
Yeah, well, great piece of advice, and also, maybe there are going to be a couple positives in looking back on this, a couple things that we can take out of this to make regular practice a little bit more efficient, or eliminate some of the not so crucial in-person cases or something like that. I don't know. There's always positives to take out of it.
Sure. Like I have patients flying from all over Ontario to come see me, and sometimes it's reviewing an MRI that takes less than 30 seconds. So they're flying, literally coming the day before, going up in a hotel, coming to see me. We talk about an MRI for 30 seconds and they go home. And it's not a very, and that's, on the OHIP's paying for that too. So I think there's going to be definitely certain things that we've learned through this process. There's certain crucial things that we have to see patients in person. But I think this has really changed the way we look at things. When I look at a patient, a fracture clinic of 70 people, and probably 30 of them didn't really need to come in. They just needed a quick conversation. It's a 1-year follow-up. How are you doing? I'm doing great. All right, see you later. Very straightforward follow-ups. So I think definitely this whole kind of situation has taught us about how we can kind of better optimize the virtual visits in a way that makes it more cost-effective. Because even look at a regular fracture clinic, when a patient walks through the door, it costs OHIP about $600 for one patient just to walk in. Now we're calling a patient and OHIP's paying me $20. So the difference in terms of the cost savings is pretty significant. So I think there's going to be definitely some changes in the way we do things. We're kind of forced to do it that way. We're going to be forced to change the way we do things for the next 6 months at least. And there may be actually, efficiency and cost savings to the system as well.
Right. Yeah. So definitely, I mean, some positives that'll certainly affect you and your practice, but it'll affect, on positive, hopefully a little bit for OHIP, save a little bit of money or change the way things are done, creates a little bit more efficiency. You touched on follow-ups and things like that. So I know one of the burning questions for most therapists is like, how do I get in touch with an orthopedic surgeon, or how do I have regular contact with an orthopedic surgeon or a physician or a sports medicine doctor? When I'm either working with a high school team or in an organization that doesn't have necessarily the inflow or outflow like a university or professional team. Do you have any advice in terms of reaching out to try and get somebody on board, or have somebody that would refer regularly?
It's a challenge, because obviously I've worked with you and Britt, who I think is on this call as well, and we've established a relationship where if you guys have any athletes who need something, I see them right away. Even the case that I'll be presenting today kind of started with a text message from Brittany saying, one of my guys hurt his ankle, can you see him? And I see him that week. It is a bit challenging because, as you can imagine, in our position, there's only a limited amount of people we can stay in touch with, because otherwise, as of right now, I'll probably get minimum of 5 phone calls a day from outside sources from the hospital asking for advice, and it does become challenging just to get back to everybody, and at least 5 emails to 10 emails a day asking questions about things. It becomes challenging from a time perspective for us. So I think the best way to do that would be to, like what you did and what Britt did, is to establish a relationship that your team or your clinic has with a specific surgeon, and establish a referral pattern back and forth. So you refer someone to me, and obviously we stay in touch with that specific patient. And when it comes time to therapy, we can stay in communication that way as well. And a lot of it, really, to me, the way I've approached it is, when I first started, I was really having challenges with that, because, like I said, 5 to 10 emails to 5 to 10 phone calls a day asking for advice, and it just became, I just couldn't handle the volume. So, for example, for one of the clinics I work at, I created a rehab protocol for every one of my surgeries. So instead of having to communicate with my therapists on email or in person or in text, they have my very detailed protocol with it, which is way more detailed than I can ever get into with just a regular phone conversation. So by doing that extra preparation beforehand, which it probably took me 20 to 40 hours to put all that work together, it definitely saves time after. It saves the way of communicating without actually physically communicating or communicating on the phone. So now I basically, I have my protocols. They have my protocols, and it's just a matter of, write down, decide protocol for this, and there's really no back and forth at all anymore because they know exactly what I want. It's the protocol is detailed, and if there are any issues, which happen once in a while, then they can get in touch with me. But that's kind of the only time I really have to actually communicate with them in real time.
Yeah, awesome. Like the protocols that you write out, heavily detailed, but not necessarily common for surgeons to have really detailed protocols, right? So that's that's amazing that you have that, and that's really helpful for therapists for sure. But it's not common, right, for most orthopedic surgeons.
No, because the reality is like it takes time to put that together, right? So to me, like I said, probably took me 20 to 40 hours, maybe longer. I don't remember now. It's been a few years, but to me, like that compared to writing, ankle range of motion, like what does that actually mean, right? It doesn't mean anything. When can they start? How much can they do? Is it passive active? Is it pain? Like there's so many different factors, and the therapist will come back saying, can you please clarify this? Each time a communication comes back to you, that's time. So to me, if I'm putting, 1 hour of my time today, it saves me 5 hours of my time later. And it also just makes the communication more effective. It's better for the patients, better for the therapist, it's better for everybody. So to me, there's no reason not to do it, but it's a matter of putting that extra time in initially, that upfront time, which it takes a long time. I'm during COVID, I've now kind of optimized the way I kind of write my notes, and I set up templates. It's taken hundreds of hours, but those hundreds of hours over the next 5 years are going to save me thousands of hours. And I look at it that way to save time now and do what's best for the patient in the long term. And it's just a much better way of communicating. Like I said, like I used to write the same thing, right? Strength, range of motion. Well, what does that really mean? It doesn't really mean anything. So now with those detailed notes, it saves me time, saves the therapist time. There's no questions about it. It's detailed. The patient gets it. I actually have a website now which posts all my information for my patients. All those things take upfront time, but the upfront time pays off in the long term.
Yeah, you bring up some amazing points to that. I mean, for any walk of life, but certainly when dealing with humans and human performance and sport, doing the upfront time obviously saves time in the long run, but also putting the human first. You're really putting that almost personal spin on it. If person A and person B have the same surgery, but the tissue isn't the same or the outcome isn't the same surgically, you can kind of tweak it. And that comes from your massively impressive background in terms of your education through your undergraduate, your graduate, and then all the things you've done in medicine and your and obviously moving into orthopedics. So that's amazing. And I know you have a bunch of published articles. So anybody who's on the chat, there's a ton of good articles. You can simply just Google Dr. Desai, Sagar Desai, and peer-reviewed journals, and you'll find a whole whack of them that he's been an author or co-author on or a reviewer on. And that's one thing that therapists can do if they don't have access to a surgeon too, is go to the literature and look at what the protocols that are in place, look at what the surgery actually entails. I think that's a huge one for therapists, both young and old, is to understand the actual procedure that's being done. And that's where we were so lucky to have access to you. And when I was at York, and then continuing on, and Britt and Tracy, and then that have access to you on a regular basis through York University now, is reaching out to talk about, how did the surgery go? And not just for, yep, it was good, but for, the tissue looked like, one question that I've always asked surgeons is what did the tissue look like? How did the tissue look when you got inside versus the orthopedic exam externally? And that kind of makes a difference, because if you say it was crappy tissue inside, then you can expect a different outcome. And I don't know, dialoguing with surgeons is massively important if you can get access and if there is a relationship there. So, and again, like you providing this information to everybody on this chat tonight, I really, really appreciate it, because it goes a long way just in building relationships and networking and understanding sort of the ins and outs. So really, really appreciate you being here. And we have a couple common cases that actually one of the football guys was on from when I was at York, who went on into the CFL, and he was a non-surgical case, but you and I went back and forth on a conservative approach to him, and we sort of went back and forth on the protocol as well, and what we were going to do to keep him from surgery, because the timeline really worked out for him to get drafted. That was one he was on. He talked about it a couple weeks ago on here, and then the other one was a wrestler who won a world championship, and then she, a couple days after winning a world championship, she had an unfortunate accident on a bus and ended up with a Liz Frank fracture, and she gave me permission to talk about it with you on here rather briefly, but let me just pull up one quick before we get to your slideshow and all of this. But this was her foot with the Liz Frank fracture on the right side, and then after repair, Dr. Desai did the repair on the right side. And this was, what was your protocol for Liz Frank repair? It's non-weight bearing for 8 weeks. Is that right?
Yeah, this is a bit of a unique case. The fixation I used here, I don't use very often, to be honest. I think I've only done it maybe a handful of times. And if you guys can see that there on the right of the screen, you basically just see two kind of metallic objects, right? And essentially what that is, it's a tight rope, which I'll talk about a little bit later. It's basically suture material between two buttons that goes across between the cuneiform and the second metatarsal. And basically, this is a bit of a unique one. She was 20, I believe Alex was 21 at the time. And she had an isolated injury between the middle and second column, so first and second column. So in her case, I basically I made her non-weight bearing for 8 weeks, which is pretty much my standard, pretty much for everybody with a Liz Frank injury, regardless of, in some cases it's 3 months, but very rarely. So for her, it's basically protocols, essentially 2 months non-weight bearing. With the advent of air casts, which have been around for a long time, but we're using them a lot differently in the last maybe 5 to 10 years. I pretty much never have I can't remember the last time I put a circumferential cast on a patient for more than 2 weeks. I mean, it just some guys still do that, but I don't anymore. Basically, it's a 2-week period of a cast after surgery. Stitches come out, and at the 2-week mark, transition to an air cast, which is essentially just a cast. But they still can't weight bear for 6 weeks. But the nice thing about the air cast is obviously for hygiene, you can take it off, wash your foot, and then I always in all these patients, I start with a range of motion, some gentle range of motion of the ankle, inversion, eversion, dorsiflexion, plantar flexion in the first 6 weeks. The goal being that at the 8-week mark, when they start walking on it, all we're really working on is now strength, and we're not working on range of motion anymore, because the range of motion, my goal for them as a range of motion is full by the 8-week mark when they can start walking on it. So that was my protocol for her, and I haven't seen her in probably about 6 months, but she was doing extremely well the last time I talked to her anyways. But she's also one of those girls that she'll do well regardless. She's kind of a pretty positive person, a very hard worker. So
Yeah, it was an interesting case. She's always very much, she's a kinesiology major as well, and she came, within inches of qualifying for what would have been the Olympics this year. Just missed out, but she actually flew down here as she was about ready to take off the boot, and she flew down to Bahamas on her own dime and hung out at a hostel, and I met her every day at the beach. As soon as she got out of the boot, we just said, there's a little bit of vitamin D down here. You're in the winter right now. When he talks about strength and full weight bearing, it doesn't mean on ice and crappy conditions out in the streets of Toronto. So why don't you fly down here? She flew down here, own dollar, amazing. We met every day on the beach and just did a ton of range of motion and strengthening, just intrinsic strengthening and stuff in the sand. And it was fantastic. She's just one of those go-getters that, yeah, you're right. She would do amazing, but what a procedure. And she knew everything about what you had done, and you had walked her through it. I'm sure she had a ton of questions because that's the type of person she is. But and the rehab went really, really well. And so she went on after that. So really, really appreciate everything that you do for the athletes. And I know they do too. Sometimes they don't say thank you as much as they should. So we do appreciate it, man. And it was an interesting case for me. I hadn't seen her either. And was just kind of coming in, and she asked, "Hey, where are you? What are you doing? Can you see me?" And I was like, "Sure, come on down." And she actually did. So it was the same kind of thing. Not every athlete would do that.
Standard now for that kind of fracture. Like I have changed my I do that sometimes, but now mainly it's kind of solid screw fixation for those type of Liz Franks. Young patient athletes, I usually put solid screw fixation wherever necessary. In her case, it was a bit of a unique case, so I did something kind of outside the box. But you would see that if you see most surgeons who do a lot of this would fix this with multiple screws and and take the screws out after 3 to 6 months, depending on various different things. There is I guess a push in the last, say, 10 to 15 years to fuse those joints right off the bat. And there's some studies showing that fusions actually might do better. But for the most part, I would say young patients, athletes, they get fixed with screws and the screws come out.
Yeah. Well, I mean, and I think you took into consideration as well the fact that she's a wrestler. She's not just, she doesn't not need that portion of her foot. She shoots off of that foot. It's her shooting foot. And if you're familiar with the sport and you understand the mechanics and biomechanics, which you do probably better than anybody else, it makes a difference to have that, to probably not have to go back in there after 3 to 6 months and pull some.
You're right. Like that's the thought process. That's the company that makes this device. That's their push, right? Is that and I'll get into the syndesmosis fixation later, but it's basically providing stable but flexible fixation, which avoids hardware breakage and requirement for removal of hardware. And that's the thought process behind these devices, is to open it, get a reduction, hold the reduction with the device, and the device allows for a little bit of mobility and does not require removal. And I guess that doesn't, in a lot of cases, these screws would break if you leave them in too long. And again, this is still a flexible device, so there's no breakage of the screw. So there are theoretical benefits of what I did, and that was my thought process with her. I think I operated on her maybe, I can't remember how long ago now. It's been probably 3 years at least, 2 or 3 years. I've changed the way I do things a little bit, and now I'm using essentially solid screw fixation for all of mine and taking them out.
Okay. Yeah, I mean, the innovative science behind it is even eye-opening for most of us, how far things have come in terms of surgery, and just looking into what the innovation, how things started and where it's moving. And I know the literature is leaned on heavily for all of these things. So anybody who's out there that's interested in orthopedics, before running to ask questions, it's really a good idea to jump into some of the literature and see what's going on, especially if your patients are surgical, pre-surgical, or post-surgical, to have an understanding as to what was done, what materials were used, and what tissue was interrupted. It just goes a long way in making it patient focused, but also making it a relevant rehab. So yeah, man, really good stuff. Appreciate the insight. And those were 2 athletes, one that's been on here. Alex will be on here at some point as a guest. Just a phenomenal rehab in terms of how she did, and their follow-ups with you are always sort of bang on, and she's very appreciative of it. So why don't we jump into that? I'll pull up your slideshow. We'll talk about that syndesmosis, so you can give us a rundown. Britt was having a bit of issue with her computer, but she's on here now. So she was Britt Enright-Blount is the head athletic therapist with the York University football team, just for anybody who's unaware of that. She's on here. She has a great relationship with Dr. Desai, and they went back and forth on this case. So let me just flip my screen over here and see if I can pull up your slideshow. Just give me 1 second, and it should be right here. Are we good there? I have yeah. Everybody can see that?
If you go to full screen, that'll be good, so you don't see the side.
Yeah, let me just get rid of that and do that. Where am I at?
So would this be the videos, James, or not?
I don't think I have the videos on here, but we can walk through and we'll go. Let me see if I can get them up as you go.
Not as tech savvy as you, but can you do a screen share that I can do it? I'm not sure if that's even possible, but
yeah, if you pull up your, you can pull it up and just do a screen share. I'll stop mine and then you pull yours up, and it should be able to. You have full access to do so, I believe. You call me tech savvy, but I actually have zero clue what I'm doing here. So I'm just sitting in front of a screen trying to have a conversation with you.
Can you see my screen now, or?
No, just you.
Oh, so I'm not sure how to do a screen share. If any millennials out there, let us know.
Yeah, anybody on there that's a guru with this stuff.
It's not a huge deal. The videos are nice, but they're not.
You have to make him a co-host.
Yep. Okay, let me play around with that. But just maybe give us a rundown on Britt. You want to just run us through the injury? There is a picture on here, but as I just fool around, we just walk through the injury mechanism and things like that.
Yeah. So we were at Queens, I do believe, last game of the season, last game of this athlete's career in university, and in the second quarter, towards close to halftime. He decided to, he's a quarterback, decided to run with the ball. Two guys tackled him. His left ankle completely turned around. So complete eversion, external rotation. And, when we walked out there, he was like, I'm done. We figured there was something pretty major going on. We got him off the field, had quite a bit of spasm in his gastroc Achilles. Figured it was broken. There's some crepitus when you did squish tests, like between tib and fib. So we air casted him. I ended up going with the paramedics and the doctors that were there at the time. We stretchered him off and took care of him that way. And I think that evening I messaged Dr. Desai to see if he could see him early in the week. So.
Right on. Okay. Appreciate the insight always. You'll go back and forth here. You guys have, I think we have, there you go. Yeah. So you have it now, and that is looking good. So you just roll with it, and I'm just in the background. Go for it.
So just to confirm, you guys can see, right? The tuck? Perfect. So this is just my approach to these injuries. I've kind of become someone who does a lot of these now. I do at least one a week, sometimes up to 3 or 4 of these a week. So I've done a lot of these, and I've changed the way I practice over the last 5 years. And this is kind of just my approach based on my experience with this and the literature. So first of all, I think I don't think you guys can see that picture, but this is the picture this is the actual image. It's a little hard to see because there's so many legs in the way there, but the guy's sitting on his foot, and his foot's essentially pointed 180 degrees the opposite direction. Put a little red circle around there, pretty obvious to see. He's 21 years old, football player, as kind of Britt already mentioned. And here's his x-ray. So kind of a standard approach. I don't want to kind of talk too basic, but see a patient who had a rotational mechanism of the ankle. And if you look at the right side of the screen there, so the AP X-ray kind of looks normal, right? So there's no real fractures. I mean, you can argue that the mortise might be a bit off, but it's not really, that's basically going to be read as normal by pretty much any physician or radiologist. So anyone that comes into me that has a rotational mechanism to their ankle with a normal ankle X-ray, it really comes down to a couple of different things. The first thing I look at is obviously the mechanism. So for instance, like I didn't have the information Britt had in terms of that picture. So if you look at the picture, it's like I can take him into the OR without X-rays, right? It's pretty straightforward what exactly happened. But the bottom line is I look at this X-ray, it's normal. I next look at what was the mechanism of injury. Did he have a simple eversion ankle mechanism? Because simple eversion ankle mechanism, you do an exam on the ankle and it's just standard anterolateral ankle pain, then it's really not a big deal. You just kind of proceed with an ankle sprain. In these cases, when I see someone who has a lot of swelling, a lot of pain, or a mechanism that's a pronation mechanism, so which means that they externally rotate their foot, I always kind of look at the next level. So someone who has a significant pronation mechanism, by definition, kind of a PER type, pronation external rotation type injury. One thing I look at is obviously proximally. So you look at the proximal X-rays, like a knee X-ray, which you can see on the left there, which is kind of pathognomonic, right? So you have a very classic kind of Mason-Neuf type ankle injury, pretty straightforward. If that's normal, and a patient has a very significant rotational mechanism, if there's any signs on the X-ray of anything concerning, I do get a CT scan. And I've picked out a number of syndesmotic injuries on CT scan that were basically completely normal X-rays. So this case was actually very straightforward, regardless of his mechanism. If you just look at the X-rays, standard Mason-Neuf type of ankle fracture. You guys can see my mouse, right? I think.
Yeah, we can see your mouse.
So obviously the force goes through the ankle, the deltoid ligament is torn, through the ankle. The force goes through the syndesmosis and exits proximally. So here's a CT scan. So the CT scan is very important to get a bilateral CT scan, which is not commonly done by most people. And the reason is obviously, it's pretty obvious, right? Like if you look at the right of the screen, which is the injury film, if you got that film in isolation and didn't have a comparative on the opposite side, you may look at that as normal, right? Because who knows what's the average, the average space between the tib fib. It's highly variable amongst patients. This one is pretty obvious, but in subtle cases, you do need that direct comparison. So I always get a bilateral CT scan. I find the MRIs aren't terribly helpful in these, unless the CT is normal, X-ray is normal, then the MRI can maybe show like a sprain, like an AITFL sprain. But in these cases, the CT is actually the best test. It gives you the best comparison side to side, because when you get an MRI, you're never, well, at least I never get bilateral MRIs. They just take too long to get. So here's pretty obvious, right? Like sometimes you have to measure these out, but you don't even need to measure these ones out. This is pretty clear. This is a clear space on either side is different. The other thing I always am careful of when I look at these x-rays, if you look very carefully, you see this extra white right here and right through here. That means like as we're scrolling through, you want to make sure that the feet were kind of in the same position on both sides, right? You want to make sure you're right at the ankle joint line. In some cases, for whatever reason, the patient's knees bent a little bit. So when you're looking at this nice image here, it's actually at two different levels of the ankle. So I always make sure it's the proper level. And if it's not, then I'll freeze it, look at the one side, and I'll go to the other side and measure it out. Again, this is pretty straightforward, and everyone can see there. This is completely gapped. I don't remember why he got a CT scan. To be honest with you, normally in a case where I see that X-ray, unless I see any obvious kind of posterior injury. So for example, you can get a Maisonneuve type of injury with a posterior malleolar fracture. In those cases, I usually get a CT scan to look at the size of that fracture to determine if that needs to be fixed as well. In these straightforward Maisonneuve cases with no obvious posterior injury, I don't usually get a CT scan because you kind of know what it's going to show. So the steps I take, I look at a couple of different things. So first of all, if you look at a stress view, so medical legally, I always save a stress view, whether it's necessary or not, it's debatable, but I just do it. So here's a video of an intraoperative video. So I'm basically just doing an external rotation stress test, and pretty obvious, right? Deltoid is gone, syndesmosis is gone. So if you look at the medial side, there's a huge gapping with during the test. And if you look at the actual tib-fib overlap at the distal aspect of the kind of syndesmosis, I'll play that again. Pretty obvious, right? And this is like I said, this is a very straightforward case because it's just so obvious based on this mechanism, based on the x-rays. This is just as easy as it gets. In the cases that are much more subtle, where you're not 100% sure if there's deltoid ligament injury, if there's full syndesmotic injury, in those cases, this stress test becomes valuable. In this particular case, I did this simply because, like, normally if I'm just doing this operation, I wouldn't even do a stress test because I know what it's going to look like. I think the reason why I did this because I was making a talk on it, so I actually just saved the video. That's the only reason why. In this particular case, I would even do a stress test because it's so straightforward. So in his case, clearly he has a complete deltoid ligament injury, superficial and deep, and a complete syndesmotic injury. Again, easily seen on an X-ray, but this is just kind of confirms that. So I always kind of save an image just for myself. The next thing I look at is fibular position. This is not a standard approach, and I'd say most of my colleagues don't do this, but I personally do this. And if you look at the reason why I do this, because we're always taught that the fibula is kind of supposed to sit in the posterior 1/3 of the plafond. The problem with that is that, my fibula sits in a different position than James's fibula, than the next person's fibula. So just to say that, the fibula should be in the posterior 1/3 is a pretty gross measure of where the fibula should sit. The reason why this becomes important is because when you do the surgery and you reduce the syndesmosis and you fix it, you want to make sure that you're not malreducing the syndesmosis, even though you're looking right at it. The most common way we malreduce these is kind of anteriorly, kind of malreduce it anteriorly. So I always take a quick X-ray, take a look at where before we even scrub in, I take a quick X-ray of the opposite unaffected ankle, a perfect lateral, and the perfect lateral, I mean, is pretty straightforward. You can see a perfect talus. There's no overlap. and I look at both sides, and I just basically look at the distance between the posterior fibula and the posterior aspect of the tibia, and I look at the difference between those two. I measure it out, and I know that when I actually do my fibula fixation and I go back and I take another lateral X-ray, I want to make sure that it's the same. This is an extra step I probably started doing in the last 2 years. I'd never been taught it before, and I'd say most people don't do this step, but it just just kind of makes me feel a little bit better that I'm getting the fibula in the right spot. And here's a kind of a blown up CT again of looking at that specifically, and looking at on this side, the fibula is more anteriorly kind of malreduced compared to this side. So this is the injured side, uninjured side. So the next step I use is basically I open the syndesmosis. So if for those of you who have some experience with rehabbing post-operative syndesmotic injuries, and I'm sure I'd assume most people would, James. I don't. I'm assuming you guys have seen post-operative syndesmotic injuries. If you look at these, like even to this day, and maybe more so, maybe 5 to 10 years ago, you see these patients come to you and they basically have, two little kind of percutaneous incisions, which basically means you look at that X-ray that I showed you before of the stress test, and kind of the quote unquote old school way of doing things was simply just to kind of take a big clamp the syndesmosis together and fire some screws across. It's been, I think, I would say it's kind of definitively proven now that that's not the right way to do things. To this day, I still see it done. I still see patients come back to me, operated on elsewhere, and they've had these percutaneous little incisions, and it was essentially reduced blind. At this stage, I think the standard of care would suggest that you'd have to do an open approach, which means you have to look at the syndesmosis, which means you have to make a big incision. So I haven't made a percutaneous incision in probably maybe 5 years now. It's a big incision, open it right up, look at the syndesmosis, reduce it properly by looking straight at it. And there's a ton of evidence to support this. Probably the best study was a Journal of Trauma study a number of years ago, which compared malreduction rates of percutaneous versus open. And they determined that by postoperative CT. They would fix it. They would fix it percutaneously. They'd fix it open. They compared them directly, and it's shown that there's a comparison of about 40% malreduction rate percutaneous versus about 15% open. So to me now, I pretty much always do a straight lateral incision. So here's an intraoperative photo. I obviously outlined where the fibula is, and I personally make my incision straight lateral, kind of right in the mid aspect of the fibula. Some people like to tail their incision a bit more anterior so they can get a better look into the syndesmosis here. So again, this is the lateral side of his foot. This is the fibula. There's my incision. Pretty big incision, right? It's probably at least kind of 8 to 10 centimeters long. And what I'm pointing at right there, just the distal tib fib area right there. So that's where the syndesmosis reduction is assessed. Then I use a laminar spreader. Laminar spreader is just basically something that spreads two bones apart, and I clear the syndesmosis. The downside with any syndesmotic injury is once the syndesmosis is torn, two different things can happen. One is that the ligaments are torn. Those ligaments get caught inside the syndesmosis, which coming to your reduction, it blocks the reduction. The second thing that happens is if you looked at that previous X-ray with the stress view, clearly the deltoid ligament is completely torn off. And the way the deltoid ligament is torn off, it gets pulled off like a big sleeve most of the time. And sometimes that big sleeve pulls off and just gets caught in the joint itself, which blocks the reduction. So there's basically two areas of where the reduction can block. So in this particular case, this video is not terrible actually. Laminar spreader right there. And there's your tib fib joint right there. So basically just take a simple pituitary rongeur just to clear out that syndesmosis. And then the reduction really depends, like, again, the kind of way we're always been taught is to use a big clamp, like a big, it's called a reduction clamp, where you just basically clamp the tibia and the fibula together, and you basically just jam it together with these big, huge jaws that are extremely powerful. I find that if you get to these fractures in a reasonable time, so I pretty much always get to these fractures within a week, sometimes 2 weeks if it's really swollen, the reduction can be done manually. You don't need any special equipment. You don't need anything. You just manually reduce it with your thumb. Again, so here's a picture. Here's a video. There's obviously the fibula right there. There's your syndesmosis, and you obviously, can you see that? That's a really quick video. Sorry about that. As I'm moving it, the entire syndesmosis is unstable. You can see the whole thing, flopping right open. That's not normal. So your anterior, so that just to kind of navigate, to kind of get you to understand where I am specifically in the ankle, that's your, essentially right there is where your anterior inferior tib fib ligament is. So that's your inferior aspect syndesmosis. That's where you kind of judge your reduction. There should be some movement there, right? So as you guys know, when you dorsiflex your ankle, there's some external rotation of the fibula. That's normal. This would be considered highly abnormal. There shouldn't be that much. There should be a ligament there. First of all, there's no ligaments there. And that's just grossly unstable. The next thing I do is I just use my finger or my thumb. And I just basically use a sucker to see exactly where the reduction is. I hold it down and I place a pin across it. So I find this pretty effective. You don't need a big clamp. I haven't used a clamp in a number of years now. You just push it down with your thumb, and it actually can get a good reduction in an acute scenario. If it's a chronic scenario, there's a very odd scenarios in this country. Happens very rarely in this country, but I've had some patients from out of the country, different parts of Africa, Asia, all kinds of places. They come to Canada, and they had a syndesmosis injury. I had a 24-year-old kid once, syndesmosis injury, and it was treated non-operatively, and his whole ankle was just dislocated for 9 months, like grossly dislocated for 9 months. So in that case, this is not quite as straightforward because there's going to be scar tissue, etc. In this particular case, it's pretty straightforward. His injury was like less than a week ago. You can get that reduction pretty easily with your thumb. And then you pin it and hold it in place. And this is another thing where not everyone does, but I think it's a really good kind of trick, is to hold it down, pin it, and hold it in place. So some people like to put the pin up higher, but to me, that's where the reduction is. I pin it right at the joint line. So here's just an X-ray. I kind of jumped forward a few steps by putting a plate on there, but that's not really relevant. The relevant part is that, one, I open the syndesmosis up, and that pin that you saw me put in is right there, right where the syndesmosis is, and that holds it reduced. I won't get into what I did here, but in these cases, I would do a deltoid ligament repair as well. In these young athletes, I do a deltoid ligament repair in these types of injuries all the time now. So I didn't want to get into too much of that for today, but like I said, the deltoid ligament, there's obviously a deep deltoid and superficial deltoid. What you'll notice that with these deltoid ligament repairs, like just so you know, there's no good, like if you see a lot of your patients without medial incisions, it's not because your surgeon was wrong and I'm right. There's no real good consensus as to what to do on this. And to be honest, the literature, from my perspective, doesn't really kind of necessarily support doing the deltoid ligament repair or not. So it's pretty standard that a lot of surgeons would not repair the deltoid ligament. So it's completely reasonable. In these particular cases, in these athletes, I do fix it, and it's pretty straightforward. I mean, it honestly adds 5 minutes to the procedure. You just make an incision on the side here. That deltoid ligament often is torn and caught in the joint. You just pull it out, put a little suture anchor in. It's actually a very straightforward operation. It takes literally another 5 minutes and adds to the procedure. And to me, I do that in pretty much every athlete with a syndesmotic injury now. But to leave that for a second, so once this is reduced, here I put a plate on, and what you'll see in a second is you can use a plate. You don't have to use a plate. There's multiple different kind of options in terms of fixing a syndesmosis. So what you guys are probably used to, and what I was used to my entire career, I started orthopedics in 2008, and I basically used 2 screws for pretty much every syndesmosis, all through my residency training and all through my fellowships training. It wasn't until maybe 4 years ago, where I started kind of using different techniques. But screw fixation's kind of what I would say that kind of the standard, which you guys have probably seen. And then there's different kind of thought processes in terms of, if you do a screw or not. Do you do 1 screw? Do you do 2 screws? Do you do 1 screw that's 3.5 millimeters? Do you do 4.5 millimeters? There's so many different variations in terms of how you fix the syndesmosis. From my perspective, I think the most important thing is to get a proper syndesmotic reduction, however you fix it. Because the reality is, with this type of injury and this type of surgery, if you just look at the economics of it, you put a screw across. I'm not even sure how much a screw costs, like $5 maybe. I don't even know, maybe $10. Maybe that's even a higher high. With this flexible fixation, which I'm going to show you in a second, you're looking at $700 to $800. So the difference between, say, 2 screws versus, say, 2 of the flexible fixation, you're looking at, do the math, right? It's like $1,400, $1,500, $1,600 for one patient. So from an economic perspective, not all hospitals can afford that. Not all hospitals have bought into it. And my hospital has, because I believe in it. And the benefits, there's a lot of literature out there supporting the flexible fixation. And a lot of people have bought into it that prior to the last few years have not bought into it. And it's slowly becoming kind of more of a standard. Definitely hasn't taken over as a standard of care, but it's slowly kind of, the benefits are slowly being seen, even in big trials, big studies, Canadian studies, and even studies that aren't industry funded. There's some good literature on it. But to me, the bottom line is, if you get a proper reduction, I personally think I like the flexible fixation better. But as long as you get a proper reduction, screw fixation still is very reasonable. So here's how I did it. I'm basically, you can basically put, so this is the fixation. There's a button here. This is all, I basically drill a hole here. This is all suture all the way across here, and a button on the other side. So if you imagine, I basically just drilled it, put the screw right. It's called a tightrope if you guys want to look it up. There's tons of videos on YouTube just to kind of show you the technique of it. So you can use, again, one tightrope, two tightropes, one screw, two screws, two tightropes, and a plate. There's all different combinations. I personally, now I use a 2-hole plate. So basically just imagine that the plate only goes from here to here. The only reason why I use a 4-hole plate here is because the set didn't have a 2-hole plate. So I had no choice but to use this. I like the plate as a buttress, but this is essentially most of the fixation option that I use for young athletes with syndesmotic injuries is 2 tight ropes with a 2-hole plate. And again, I thought I had a video of that, but obviously I didn't. You just go on YouTube and just type in, it's just, the product is it's an Arthrex product. It's called a tightrope. My website also has a video under ankle fractures as well that just shows the general technique of it. Just to take, just watch it once and it's pretty straightforward. In terms of how do you do it, I try to do the 2 tight ropes for greater strength for athletes. I try to get them in 2 different trajectories to theoretically kind of better copy what the normal syndesmosis does. But again, these are all very debatable topics. So my post-op protocol is the same pretty much for every ankle fracture for now. Nowadays, there's new literature coming out in straightforward ankle fractures without significant syndesmosis injury. You can actually start letting patients weight bear right away. So in my standard ankle fractures now, I usually do a cast for 2 weeks. And the only reason why I put a cast on for 2 weeks, I pretty much put a cast on everybody for 2 weeks for pretty much every operation. And the only reason why I do that is just to allow the wound to heal properly. It's a little bit on the mean side, but I do put a big bulky cast on, just so the patient doesn't move. And that sounds terrible to do that, but I've learned over the years and that if you don't put the proper casting on, patients are going to walk on it, they're going to move, they're going to do all kinds of stuff. So now I put a pretty big bulky cast on for 2 weeks. I let the wound heal. In a regular ankle fracture, they start getting into a boot at the 2-week mark and just start walking on it right off the bat. There's good studies showing good functional outcomes by early weight bearing. And if you think about it, 2 different reasons why I think that's true is, number one, the fibula takes so little of the actual weight bearing. There's 10% of the weight bearing through a fibula. So if you have a regular fibular fracture, there's so little force going through that fibula with basic walking that it shouldn't displace. And number 2, most patients are going to self-regulate based on their pain, right? So if someone's in a lot of pain, they're not going to put a whole lot of weight on it. And what I've seen in my practice since I've started doing the full weight bearing of the 2-week mark, is people don't put weight on it anyways because they're just scared and it hurts. So, but they're allowed to do it. And those patients who have done it that actually walk on it, they've done pretty well. So I do a walking boot for 2 to 8 weeks. In my regular ankle fractures, I usually do a walking boot for 6 weeks, and I get at the 6-week mark, they get out of the boot. In a syndesmotic injury, I'm much more careful. It's a much more significant injury. There's a deltoid ligament repair. So I do a little bit more cautious and do the full 8 weeks of non-weight bearing and the full 8 weeks in the air cast. Now that's just a formula I've used with good success. And during that time, that's where I usually send them to a therapist at this time at the 2-week mark. And to me, the worst possible scenario. So I honestly, I fix at least 1 up to 4 ankle fractures a day in my trauma rooms. And the patients that do poorly, I found over the years, are the ones that, that don't do anything for the first 6 to 8 weeks. And they always come back saying, "Oh, you told me not to do anything," even though I clearly gave them instructions, and my website clearly says to do it, but they just don't like doing the motion initially just because it's painful. It's big, it's swollen, it's painful. They're uncomfortable. They don't like the boot. They're just getting used to the boot. They've never had a boot before. It's difficult for patients, and that's where the therapist comes in to really encourage them to push the range of motion right away. And the reason why I do that is from the 2 to 6 or 2 to 8 week mark. To me, that's the key, because the worst case scenario at the 6 to 8 week mark, they haven't done anything. Just like the old school kind of circumferential fiberglass cast, which some guys still use. It's hard to ever get range of motion back at that stage. So to me, it's important to get that range of motion started right away. And the fixation techniques, the fixation implants now are so strong that they can withstand that range of motion. So for the first 2 to 8 weeks, their instructions are very clear that they have the boot on all the time. So it's basically just like a cast. They take it off to take a shower, and they can take it off 3 times a day to work on range of motion, both passively and actively. And the goal being, and I just make it very clear to patients, I take their shoe off on the other side, and I said, in 6 to 8 weeks, when I see you back, I want their range of motion on both sides to be the exact same. And it's doable. And when they come back at the 6 to 8 week mark, if things look at an x-ray, now all we're really dealing with, and as you guys know this better than I do, getting range of motion late is hard. Getting strength late is very straightforward, right? Like, they're all going to get their strength back. Getting the range of motion back becomes challenging if they're not putting. And I have patients who come back 3 months later and they still haven't seen a therapist and they still have no range of motion. They're probably not going to get that motion back ever again, right? So to me, the key point in terms of the therapy is the first 6 weeks and to get the range of motion back, and the first 3 months for sure. After 3 months, obviously you guys know this better than I do. You can still gain range of motion. It's just harder. I'd rather my patients at the 6 to 8 week mark work on balance, proprioception, gait training, that type of thing, working on swelling techniques. I don't want them working on range of motion, because to me, that's something that we can get in the first 2 to 6 weeks. At the 8 week mark, we kind of wean the boot off. The weaning process, I'm sure you've done for your patients, pretty straightforward, right? Like if you work 22 hours one day, you work 20 hours the next day, you slowly walk a bit more and more out of the boot. And just to give you, this is just my technique for kind of post-operative management. I used to give 60 to 80 Percocets, and a lot of my colleagues still do, and a lot of surgeons still do this, is 60 to 80 Percocets after an ankle fracture. I personally have kind of cut down to 20 tablets at the most. And I really coach the patient on kind of what the expectations of pain are. And I'm sure you guys do the same thing. As there's good studies showing 2 different things. One is that, if you look in the States, they did studies on post-operative hip and knee replacements and looking at the prescribing habits of surgeons. And some surgeons were giving hundreds of tablets, hundreds. And if you look at the usage, first of all, patients don't even use that many. And secondly, if you look at these studies looking at, proper coaching preoperatively, I tell my patients, I'm giving you like literally my spiel is the same to everybody. For my bunions, for my toe surgeries, I do 10 tablets, sometimes 5 tablets. I tell them 20 Percocet is like double what you'll ever need. You're never going to need any more than this. But I want to give you a couple just extra just in case. Since I've done that for the past 2 years, I haven't had a single patient call in for an extra prescription because their expectation was 20 tablets was enough. The second thing, and then obviously I tailor off to just extra strength Tylenol. I think that's a really important thing that I'm not sure how much you guys get involved as therapists, but I'm sure you guys deal with patients who are in pain 2 to 6 weeks after, and you do have to deal with it. It's probably more than I do because I only see them for 5 minutes every 6 weeks. It's a challenging discussion to have in terms of the expectation of what their pain should be. And it's always a bit challenging to determine what's normal versus abnormal pain. And that's always a challenging part. But for the most part, at the 2 week mark, I never have prescribed another prescription. I never give another prescription at the 2 week mark. It's always tailor off to Advil, Tylenol. I give aspirin for everybody. That's debatable. We can talk all day about that, but there's no evidence for or against use of aspirin. But for me, it's 81 milligrams, very low risk, low probability of side effects such as gastrointestinal bleeding, and does have the possibility of improving or decreasing the risk of DVT. And the last one is vitamin C. So I give every single patient who I have surgery right now gets vitamin C. There's actually good studies showing decreased risk of CRPS with the use of vitamin C post-operatively. It's been well known for a long time, as you guys probably know, in distal radius fractures, but it's more of a recent phenomenon in the last few years for foot and ankle injuries. I get 500 every 30 days. If you look at the literature closely, it's technically 1,000 every 60 days. But the reality is, I mean, and I wouldn't use it either. Like I don't think patients are going to be taking pills for 60 days, twice a day. So I just kind of simplify it a little bit. To be honest, I don't even think my patients even take the 30 days tablets, but I think it's a good idea. And that's pretty much it. So it's a really common injury I deal with. My practice has progressed significantly over the last 2 or 3 years, even in terms of how I manage these, how I manage them post-operatively, my narcotic use post-operatively, my anticoagulation post-operatively, the CRPS prophylaxis. There's a lot of different things that you're going to see with your surgeons and your patients, and a lot of them, they might have the exact opposite of what I do. Percutaneous incision, screws, 50, 60, 70 Percocets, no aspirin, and there's no right or wrong way. That's the reality. I think there are certain things that are right or wrong, but for the most part, it's done differently amongst other surgeons. So you're going to see a lot of different ways of doing things. It's not right or wrong. This has just been my formula that I've used for a number of years now, pretty effectively, and I have a massive population of these. So I do, again, one to four a week, and it's really helped me learn a lot as well. Because as I progress through my career, I see patients early on, and I change the way I practice, and I do things completely differently than I did 5 years ago. So that's just my kind of my approach, and I'm happy to take any questions or comments.
Yeah, so many comments on my side. Anyway, you bring up so much valuable information, and I kind of, as you're going through the surgical case, and you're talking about, doing an X-ray prior to the intervention, doing the intervention, and then X-raying after to see what your effect is. I think that is translatable to rehab. That's translatable to training. That's translatable to any number of things that therapists do. So really making sure that you have an idea of where you're starting, where you're trying to get to, but making sure that you reevaluate the same way that you did the first time, like regardless of the scenario. That was massive to hear you say that in surgery, but also to just in thinking about what we do on a regular basis. If the deltoid's not repaired, but it is in the joint space, is it then just resected, or is it taken right out and just, I don't know?
Well, sorry, so maybe I wasn't very clear with that. Basically, what I would say most surgeons don't open the joint at all. So the classic teaching, the AO with classic teaching is, fibular, like a straightforward Mason-Neuf type fracture. Open the lateral side, open the syndesmosis, reduce it, fix it, leave the deltoid alone completely. In a scenario where, if you looked at the deltoid, the medial clear space, if you go through your whole fixation and you look at the medial side and it's still gapped open, there's something in there. So the classic teaching is like, all right, you can't get the mortise reduced. Go to the medial side, open it up, take that garbage out of there, and then do whatever you want with it. So a lot of surgeons won't even approach the medial side. For me, there's no good literature to honestly support necessarily going to the medial side. Having said that, with these patients, the young patients in particular, athletes, I just find it more of a stable fixation if I'm going to go medial. The deltoid is almost always torn off. Like if this is the medial mal, the deltoid literally gets torn off like this, and it's just a sleeve that goes back on. It literally takes 5 minutes, maybe 5 minutes to do the entire operation on the medial side. So I started doing that again probably a couple of years ago. Prior to that, I never did. I never opened the medial side up because that's the classic teaching. And there's a lot of we can learn from. I obviously learned from guys from who do a high volume of athletes and high volume of these as well. And I've learned from them, and I've learned that once you start seeing patients yourself, the literature can tell you one thing, as you guys know. The literature can say one thing, but once I start seeing patients myself with either medial-sided ankle pain, or does the mortise kind of look like it's gapped open, or is there some late valgus of the ankle? I just felt it more predictable in young athletes, young active people, to fix it. And I don't do it all the time. I could do tons of ankle fractures. I don't always do it, but in this particular case, I do find it valuable.
Yeah, awesome. Amazing slideshow and discussion, and just leading us through this is a huge resource in terms of all of our learning, looking at images, understanding the surgical technique, and everything that you touch on in terms of what's important in the rehab and all of that is crucial. It's amazing. Thank you so much again for being here. And a couple questions coming in that I'll just read off so you don't have to. Dr. DiNardo's on here, Luciano DiNardo. Any concerns with NSAIDs and fracture healing is the question.
Generally speaking, we don't really worry about that. The literature around NSAIDs and fracture healing is really inconclusive. There are some studies showing potential in tibial fractures. There are some studies showing potential effect. From my perspective, I haven't found it to be an issue, and I think most surgeons would not find that to be an issue. So to me, the benefit of NSAIDs post-operatively is, number one, when the patient leaves the operating room or just before the surgery is done, they usually get one dose of narcotic. And there's this whole push for kind of multimodal analgesia to help patients' pain. And to me, utilizing some NSAIDs post-operatively to decrease their narcotic use, that's more beneficial than the potential more theoretical risk of fracture, of delayed union or fracture healing issues. So to me, multimodal analgesia is kind of probably more important than worrying about a general theoretical risk of delayed fracture healing. So I tend not to even think about that as an issue.
Yeah. Awesome. It's just amazing to have access to the conversations that you're having in terms of determining what's going on with post-operative care, inoperative care, preoperative care. All these things is massive to hear for myself and for everybody on here. So really good stuff. Another question that came in is screws that are removed after the injury heals, the timeline for that. I think you said somewhere, what was the timeline for removal? And are there cases where the screws are left in?
So that's a very good question. Probably the best study in literature to date would suggest that screws don't even need to be taken out. My teaching and what I've always done in my entire career is I don't routinely take them out. So basically, what happens is obviously you reduce the syndesmosis, you put screws across, and I showed a case of a tightrope, but I use screws quite often as well, and I tend to leave them in. And what happens over time is that, as you guys know, the fibula externally rotates, it loosens. There's a halo that's created around the screws, and many times the screws actually break as well. So the reason for screw removal is debatable. So personally, I tend not to remove the screws because the literature wouldn't support it. It's another operation for the patient. The screws break. There's actually studies showing that after screws break, there's no real difference in terms of the patient's functional or pain outcomes either. So if you were to take the screws out, I usually wait around 3 months. And the times, I can't remember the last time I took a screw out, but I think sometimes patients they're so fixated, or someone told them before they were referred to me that the screws have to come out and that they just can't get it off their mind. And for whatever reason, like the ones I've taken out, the patients after say, "Oh, I feel way better." The literature wouldn't support that, but a lot of my colleagues as well who've done this longer than I have, some of them take screws out routinely, and they just say, I can't explain it, but patients just feel better after. So there is some kind of something to say for that. Someone who's done this for 30 years and have taken screws out their whole career. And one of my colleagues is an orthopedic surgeon, broke his ankle, has syndesmosis screws. He remembers the day they broke, and the day they broke, he remembers his pain went away. So although the literature wouldn't support any of that, I don't think, anecdotally, there may be some potential benefits of taking it out, but it's not necessary.
Yeah, great question, great answer, and the insight is massive. Yeah, I don't know. There's a little bit to it in terms of treating patients as well. There's a TLC factor, and hey, maybe it's just a chance to get to see you again in the operating room, and that did such a good job the first time. Let me get
and that's one of the arguments, if you think about it, with that flexible fixation. The argument from the company, from an industry perspective, is that if you look at it from a cost perspective of the screw versus the flexible device, it's like $5 versus $800. Right. Yeah. Massive difference, obviously. The question is, if you're the type of surgeon who routinely goes back to the operating room to take the screws out, the cost of that alone is far more than $800, obviously, right? The cost of a patient going through the clinic to the OR, follow-up visits for a surgery is thousands of dollars. We're talking $5,000 to $10,000 for something simple like that. So that's the argument from from an economic perspective to use the flexible devices, in addition to many other potential literature proven benefits functionally as well.
Yeah. Awesome. Really important question that just came up as I saw your arm come on the screen is, are you done getting tattooed, or are you going to get some more here in the, I don't know, post-COVID time? I got to know. That's
This is my midlife crisis tattoo.
But the arms look great. I mean, like, probably better than they did at your West.
I think it was 30. I got late in life. This was my sports car. I got the tattoo, and I was planning on getting more, but then obviously things are kind of shut down. So I might have to wait till it's safer next year.
Yeah, been wearing masks and getting tattooed. It'll be a thing. All right. Very good. Appreciate it. If anybody has any other questions for Dr. Desai, I'll give you just a minute or two to type them in here. I don't want to take up too much more of your time. That was vastly deep and just a ton of knowledge for all of us to soak in and take in, and understanding the literature, understanding that these conversations are being had in terms of technological advances, innovation in terms of surgeries, just looking at both sides of the joint, looking above, looking below, having an understanding of what the mechanism is when an injury happens plays a role in this. You touched on range of motion early. A number of us have dealt with students or are students or have been students recently. And one of the things that I've always found with students, and when I was a student, was very, very hesitant to start the range of motion post-surgery. I know it's dependent on what procedure was done, but in terms of this procedure or ankle procedures in general, you're pretty safe once they get out of the cast to start pushing that range of motion. Is that right, or what would you advise?
Yeah, I mean, obviously, I think it's up to the surgeon to tell you that. If, like, for example, if it's in a very rare case, an older patient with horrible bone quality, I'm a little bit more hesitant to start range of motion early, but pretty uncommon. But your comment on people wanting to get started in range of motion is very valid, because my patients who, literally my appointment is, my follow-up appointment is, maybe 3 minutes long, and I tell them literally 5 different times on how to work on range of motion, and a lot of patients don't do it because they're scared, right? And yeah. I get that. So I think that's why I try my best to get a therapist involved early on, because if you're seeing a therapist, and I've clearly stated instructions that you can start your therapy, having someone there to help you with it, even just to show you how to get a towel around your toe to pull your foot in, I've found that very helpful, because the reality is I can't see the patient every 3 or 4 days. It's obviously not possible, and I can't do it myself. So that's why I try to get therapists involved at the 2-week mark. A lot of people get their therapists involved kind of 6 to 8 weeks later when you're starting to walk on it. But to me, the range of motion value of a therapist is really kind of just coaching them into pushing through the discomfort and the pain. And because it's understandable too, right? It's a big swollen foot, you have a big incision. Last thing you want to do is you're at home by yourself and you're pushing your ankle range of motion. And that's obviously things that I'm sure you guys deal with far more than I do, is that balance between the patients. They think, if I rest it more, it's going to be better. If I take it easy, it's going to be better. If I don't do as much initially, it's going to heal better. When we all know that's the opposite, right? And most patients don't understand that, and I don't blame them for that, because this is not what they do for a living. So that's where I think a therapist getting involved early on and developing a relationship early on is very important. And so that's I think that's one of my comments based on that. Really getting patients to start moving quickly.
Yeah, and sometimes it's quite the opposite actually with athletes, where they want to do too much, and so it's this gentle, it's the art and the science, where we have the art of the therapist and the science to rely on in terms of when to do what and how to do it.
And I think the comment on that is, and that's a very good point. With a lot of my athletes, it's challenging to hold them back, and I've had more than a number of patients come in with syndesmotic injuries at the 6-week mark in a normal shoe, walking in. And I literally have palpitations because they had this massive syndesmotic injury. They're walking in at 6 weeks in their regular shoe. And it's you're supposed to be non-weight bearing for 8 weeks, right? So there's that opposite spectrum as well. And I think that, in those patients that I've seen that happen on, I think our technology and our surgical techniques have progressed enough, knock on wood, so far to date. And it happens honestly 3 or 4 times per clinic where someone doesn't follow the instructions. I haven't seen any major problems. So I think our techniques, the surgical implants, the technology has progressed so much that I think, if anything, we're probably babying patients too much and holding them back too much. So there is that wiggle room to kind of let them do more than they should. But I still prefer, like a young athlete, the last thing you want to do is have a setback at the 3-week mark and then progress, it costs them their entire next season too. So I'm a little bit careful with that. But I'm surprised with how much patients have been able to get away with not listening to anything I've said, anything I've told them.
Yeah, good insight, and clinically, as well as like the interaction with the therapist and how valuable that is early on. That deltoid repair would take me probably like I don't know, not 5 minutes. So appreciate you being as humble about that, taking 5 minutes. I would never obviously attempt it, but interesting to see like how quickly things can be done as well in terms of a repair like that, and understanding the slippage off that medial side. So just thinking back to that as well. And one more question for you, and then we'll let you get on your way. How influential are the economic? I mean, you touched on economic factors in terms of materials and OR time and these kinds of things, but how influential are the economic factors to making decisions during surgery? I mean, it's a reality, right, in Canada and in a
very, very good question. I think to be honest, and I'm sure you guys are no different, because your education background for the most part is similar to mine. Like, you don't learn about economics, finances in general, let alone health economics and health finances and that type of thing. You just don't learn that stuff until you guys go out and get your own business and start seeing how much, a towel costs. You don't think of these things. And just like most surgeons, we don't think of these things. And I'm sure I'm no different. Like, you're in residency, you're going through, oh yeah, pass me this screw, pass me this screw, pass me this, like these things add up, and I think as surgeons, we, I think probably more recently than anything, last 5 to 10 years, we become more responsible that way, and looking at the economics of these things. And there's no question, I can speak for myself only, that there's no question it plays a role in sometimes how I approach it. So the syndesmosis is the perfect example. If I have a patient who is more sedentary, older, not nearly as active, has a desk job, or just has a sedentary lifestyle, I'm much less likely to use an $800 implant on them, because they don't really need it. They're not going to have the benefits of that that a 20-year-old athlete would. So it's a slippery slope, because you always see at the same time want to do the absolute best for every single person, obviously. But if you did that, then we wouldn't have a system anymore, because then I'd be using synthetic bone graft for every single person, $1,000 a case. So you can, in some cases that I do, these major cases cost $10,000 just with the implants. You can't do that for everybody, because one, it's too expensive, and two, the reality is, like, they probably don't need it. So for example, a young athlete with a simple ankle fracture, I can go in and put like synthetic bone graft, it's $1,000, but do they actually need it? They're going to heal anyways. If you fix it properly, it'll heal anyways. So there's so many different factors that I take into account. And definitely I'm not cheap. Like, I do a lot of expensive implants, but you have to definitely kind of think about all aspects of it. Do they need it? Would they benefit from it? And then you balance that with, sometimes I get, like this admin kind of ask me, like, why are you using this? And if I think it's going to help that patient and avoid a non-union, for example, the cost of dealing with a non-union, going through the whole thing again, tens and tens of thousands of dollars, not thousands, we're talking tens of thousands. So if I can use $1,000 product that has a chance of decreasing the risk of non-union, which is going to cost the system $50,000, to me, it's a no-brainer. And that's the kind of model I use when it comes to using new products and getting the hospital to fund new products. That's the kind of arguments I present to them. It's like, well, here's the two options. If I can save one non-union in 10 patients, we're going to save the system X number of thousands of dollars. It's a very easy argument. The hospitals can't really argue that. And that's always comes a part of it. And it's something I've learned a lot in the last few years, because I've had to present my case to hospitals to cover certain costs that are pretty extreme, and they've covered it, because you provide them an argument that is kind of hard to turn down. So it's a very good question, and it's an ongoing thing, and it definitely plays a huge role in a publicly funded system, for sure.
Yeah, I appreciate the honest answer and the direct line to it as well. So, it's the old Leuco tape versus zinc tape debate. Who deserves this Leuco tape? Who really needs it? Because I only have one roll for the entire season. So, yeah. Anyway, listen, Doc, I really, really appreciate your time, as everybody does on here. This has been you've gone above and beyond the slideshow, the case study, the answering the questions in depth, taking time out of your evening. Can't say enough, man. Thank you so much. This means a lot to myself, to all of us on here. I'm sure we're going to have a spike in syndesmotic article reading happening here shortly. But really, really appreciate your time. And I look forward to catching up when we're back home in Canada and hopefully not over too many cases of ankle injuries, at least. And we'll go from there. But your time, invaluable. You've taught us so much in this limited time that we've had you. Really, really appreciate it. Thank you 1,000 times.
Thank you so much for having me, guys. It's been a pleasure.
All right. Well, we'll be in touch. And everybody else, thank you for being here. This has been Let's Chat, an athletic therapy roundtable, session 14. I will hang around for a little while after this. If anybody's willing to stay on and chat a little further, please feel free to do so. The quiz is available at the top of the chat over there for anybody who wishes to do that. Otherwise, email me at athletictherapyroundtable@gmail.com, and I can get it to you that way as well. Thank you very much. And I will say good night to everybody, and anybody who's hanging out, see you in a couple. Thank you very much. Good night.
Thanks again for being here. Thanks for listening. Thanks for being a part of this community. Check us out online, firststartherapy.com. That's FIRSTAR therapy.com. Or email us with feedback, consult@firststartherapy.com. CONSULT@firststartherapy.com. On Instagram @firststar.therapy, and our podcast host @letschat.at. This is First Star Let's Chat, an athletic therapy podcast.